Dr. Carla DiGirolamo. We're so happy to have you here speaking with us for Bikini Wellness Figure Competition Prep. Everybody, Dr. Carla DiGirolamo is a board-certified obstetrician, gynecologist, and reproductive endocrinologist with nearly 2 decades of experience in women's hormonal health care and Menopause Society certified practitioner. She has been recognized as the top doctor in the Boston area from 2019 to 2024. She also supports the fitness community as a certified fitness professional holding credentials in CrossFit, a certified nutrition coach, and group fitness instructor. She is helping active and high-performing women reach their potential from puberty all the way through menopause and integrating fitness and nutrition with medical therapy to ensure women thrive. Her private practice is called Dr. Carla DiGirolamo, MD, and is a pioneer in women's performance endocrinology. We are so happy to have you here.
Thank you, Chelsea. I appreciate you having me.
And just to go over our audience really quickly, we do have a robust community, Facebook community of women competitors and lifestyle athletes. They are ranging from new to seasoned athletes, young and mature. And so everyone's just in different phases of life and journey, but we do get a lot of questions around women's health since there's not a lot of information, but what information is available is super confusing to digest. So we're really excited to have you here to help them break it down and figure out what the heck is going on with our bodies.
Well, I appreciate the opportunity to connect with your audience because these are a lot of topics that I talk about all the time. And there's a lot of information out there that can be very confusing. So I'm happy to help.
Great. Let's get everybody on the same page to start off. So let's just talk about the basics of what an endocrinologist is, what do they do, and how can that apply to these female lifestyle or competitor athletes?
So an endocrinologist, and there are different types of endocrinologists. So by definition, an endocrinologist is a specialist in hormonal health. Hormones are, it's like a symphony of biochemical pathways in the body that come together and drive the processes that are necessary for life. And so a general endocrinologist, is familiar with all of the pathways that encompass the body. I am a subspecialist of that. I am a reproductive endocrinologist where my specialty focuses more on the reproductive hormone axis where, with menstruation and puberty and menopause, but also the other endocrine processes that interact directly with the reproductive pathway, and that is like the stress response. And that is probably one of the most relevant ones for female athletes. So those are the two areas that my expertise spans. Other endocrinologists might deal with thyroid disorders. Other endocrinologists might deal with Cushing's and adrenal disorders. There are lots of different subspecialties, but those are the two that I deal with.
Is it common for endocrinologists to have subspecialties?
I think in medicine in general, everything is turning into a subspecialty. I remember back in the day, it used to just be obstetrics and gynecology. And then 20 years later, there were like 5 specialties of it. And so I think that's happening to a lot of fields, and endocrinology is the same. And the reason this is happening, for better or for worse, is because we're making advances so far in so many of these fields. To keep up with it all, you really have to focus on just one thing, because it's hard to be good at too many things. And so this is just where medicine is moving as a whole. And the downside to that is that sometimes people are working in silos, like the general GYN is kind of doing their thing, and the menopause doc is kind of doing their thing, and the right hand doesn't know what the left is doing. So over the 20 plus years I've been practicing medicine, I've been watching this dynamic evolve. And so with my own practice, my model is to reach across to the other providers on my patient's care team so that we're not working in a silo, so that we're working together to help these women reach their optimum health and performance.
That collaborative care is so important. And I want to hone in on something that you said about your specialty and the stress response, because I think that's really where our community can benefit from your education. I don't know, of course, someone who's going through prep is going to have a stress response. So we can talk more about that. But what about the lifestyle athletes? Even just the type of person who's committed to tracking food and getting in all their workouts and things like that. What would you say about their stress levels and how it impacts their hormonal health?
I think the most common problem that I see in women 40 plus, probably, and even in younger women as well, but it is especially prevalent in the midlife population, is that they are not fueling adequately. They're not getting enough energy to fuel their workouts. So lifestyle athletes can be pretty intensely competitive. You know, you might have the CrossFitter that goes 4 times a week. She may run marathons when she's not doing CrossFit. You know, she may not be competitive, but she's a damn serious athlete. And that kind of training requires some special fueling. And so the most common thing I see is that women are in this low energy availability state, which is spiking their stress response. They're trying to lose that little bit of belly fat around the middle, and they can't because their body is holding on to dear life for every bit of fat cells and energy there is in the body. And so people get stuck and they get inflamed as a result of that. So the stress response activation due to inadequate energy intake is probably the most common thing I see in athletic women.
Which is great to hear from a professional, because we always come back to say it's bodybuilding. A lot of people come into the community, they just want to start cutting and losing weight, and it is bodybuilding. You really need to have that nutrition component. So I feel like you hit that home in a really succinct way.
Yeah, and you know, I went to a meeting last year. It was called the Female Athlete Conference, and this was in Boston, in my hometown. And there was a recent consensus statement published by the International Olympic Committee on LEA, low energy availability, and RED-S, which is relative energy deficiency in sport. And they quoted this really interesting article that they did on looking at what energy intake is required in these particular people. Now, this was young sedentary people, which was interesting, but to make a long story short, they are saying that we need about 45 kcals per kilogram of lean body mass. And so when you do all the calculation for like an average 130-pound woman with 20% body fat, she needs about 2,000 calories to just maintain. And this was a sedentary person. I mean, this study really hit home. It's like, oh my God, if the sedentary person needs 2,000 and she's 130 pounds, you know, 5'5", you know, 20% body weight, body fat, then what does the 6-day-a-week, you know, lifestyle athlete or even competitive athlete need? So this was a huge wake-up call, and I have given a lot of talks on exactly this, helping my medical colleagues and my fitness trainers and coaching colleagues to know that do not put them on 1,200 calories a day when they're training. Please, you're starving these poor women. And I think it's, you know, these caloric intakes are higher than we ever would expect. And so we've been fraught with diet culture for just so many years and decades. It really has taken its toll. And we're only learning now that, God, these women have to eat more to build more.
With this research, what other things can people see in their lab work that would reflect that, hey, you need to pay more attention to how much you're eating and how you're managing your stress? And also, how often should lifestyle or competitors be getting their hormones checked?
Well, it depends on what hormones we're talking about and what exactly we're looking for. It's better to take a more surgical approach than, you know, these big, massive panels that, you know, could give you some false positive results and maybe muddy the waters. So if I have a woman that comes to me and I'm suspecting that, okay, maybe her energy availability or her energy balance is off, the things that I look at first, I talk to her. That is the most important thing. Above and beyond labs, doctors these days, because of all of the tech, we have forgotten how to talk to our patients. So I spend an hour with my patients, asking them, okay, what is your story? How do you train? What's your nutrition? What are you experiencing? And based on that, I might say, okay, you might have a thyroid issue. Let's check some thyroid studies. What does your menstrual cycle do? If she is still a cycling woman, then she tells me, oh, my periods have been irregular over the last 3 months. Well, that is a huge, huge red flag that she is in low energy availability in the context of, you know, the whole story. In terms of reproductive hormones, you know, when somebody's periods are irregular, you have to rule out other things. You know, could she be prematurely going into menopause? Could she have polycystic ovarian syndrome? Could she have stuff like that? And so there's a number of tests that we would do if we were looking specifically for that. If we are particularly interested in red S, you want to look at CRP, which is C-reactive protein. That's an inflammatory modulator. You might do some serial cortisol evaluations. The Dutch test does a good job with this, but the gold standard is to collect 24 hours of urine and measure it. That's no fun and not very practical, but that is the gold standard. We look at ferritin levels, sometimes IGF-1 levels. And so that's if I'm very suspicious of red S and I can't land the diagnosis just by talking to her. So in terms of like doing a blast of, the massive hormone panel, I don't find those particularly helpful, but I do use hormone levels to try to add color to the story she tells me when we meet together.
What might somebody be feeling that would even get them into your care? You mentioned irregular cycles. We know energy levels. In our community, sometimes it's just being stuck and feeling like your body isn't responding. Those are some of the obvious things. But what are some of the other feelings that somebody may have normalized that, if they look at it a little bit differently, may get them into your care and get them some answers?
That's a really great question. So sleep disturbance is a big one when people just aren't sleeping quite right. For some reason, they can't figure it out. Something's waking them up in the middle of the night, or maybe their Whoop strap tells them that their restorative sleep has dropped. Sleep tracking data, I am a huge fan of that. I think Aura and Whoop have really gotten it right. And I think that data can be very helpful. So sleep, big one. Periods, like we said, mood, irritability, anxiety. I feel very unsettled. The other popular thing I'm told is the things that used to work don't work anymore. And what are some of the other things? Hot flashes are more related to menopause, but the sleep disturbance, the fatigue, injury. I am getting hurt so much more now. I can't seem to recover from my workouts the way I used to. I'm constantly in pain. Those are often the things that bring people to me. And in the 50 plus age group, what usually is the situation is that 50-year-old woman has gone to her OBGYN complaining of all of these things. And the OBGYN says, oh, here, take some birth control pills, you're in perimenopause. And then they come to me saying, I'm not sure that's what the reason is. And then I ask them, well, how are you training? How's your fueling? Well, I'm training for the Boston Marathon on 1,200 calories a day. Well, of course you're cranky, and of course you can't sleep, and of course you're injured. And then once we get her fueling properly, then those symptoms often resolve themselves. And so in the 50 plus population, that's often how they come to me, because their symptoms are being mistaken for perimenopause when it's really due to LEA or red S.
So with those symptoms that you just gave, you mentioned that hot flashes specifically is probably more related to menopause. So how can the athletes figure out if it is perimenopause or menopause?
Well, first thing you have to know is, well, how old are you? Where are you in your reproductive phase? If you're 25, now it's possible a 25-year-old could be prematurely menopausal. I have seen that a number of times in my career, but I can tell you it's extraordinarily rare. If the 25-year-old came to me, I would probably be checking her thyroid. I would probably be checking her for like PCOS type stuff. If she is 45, then labs aren't always helpful at 45, because a 45-year-old perimenopausal woman, her labs are going to be all over the map. You could check them at 9 a.m. and they'll be completely different than if you checked them at 3 p.m. because they're literally all over the place. So, if someone's trying to figure this out, first, how old are you? If you're 25, you might be thinking about thyroid or other things. If you're 40, it could be perimenopause. It's a little early, but it could be. And you look for those things: sleep, mood, fatigue, vaginal dryness, painful sex, things like that. When you have that constellation, that might tell you that this could be perimenopausal. And then when you're 50 plus, periods have stopped. Now you still have to, you can't just chalk it up to menopause. You still have to come in, see a professional to make sure that we're not missing anything else.
And we worry about women in our community, especially those who compete actively and they're competing at the national level. They're getting so lean and things like that. moving themselves through those phases maybe a little bit faster. Is that a legitimate concern, or is that something that can be intervened on with nutrition and giving your body time to heal? Any thoughts around that? The impact of competing, the impact of chronic dieting?
If we're talking about weight class athletes or physique athletes, where they have to achieve a certain aesthetic for their competition or for their event, or if you're a fighter and you need to make weight for your particular weight class, what we often see and what's necessary for these athletes is to go into what's called adaptable LEA. Adaptable low energy availability is when you are temporarily in a deficit to try to lose the weight to make your weight class and to try to achieve the aesthetic you need to compete in the physique competition. But then following the event or the competition, you then start fueling more imbalance with what your training is. And so when you just go through limited periods of LEA, that's okay. The key is after the event, you want to make sure that you're returned to baseline. The problem that occurs is when LEA never comes back to baseline. The event is over and people are still walking around with 8% body fat, looking shredded in the mirror. And this goes on for months and months. Now, we would all love to look that way all of the time, but that isn't the healthiest way to go. And it's not sustainable. So the important thing is to try to get back to fueling balance following the event, particularly for weight class and physique athletes.
Absolutely. And that's really helpful. And we do actually experience a lot of that in our community, where people have unrealistic expectations that they're going to stay in that state. So I'm glad that you said that. For the record, you got to come back up. It's not realistic to stay at 8% body fat. To pull us back to the outlines, we had a ton of questions. Some people gave us feedback that they have experience working with general practitioners. And so they'll go in and they'll say, hey, I'm competing. I think this is going on. Can you run my blood work? Can you check in on things? And they feel like the feedback is not surprisingly too general. What should they be asking for to make sure that they're dialing in their questions for what needs to be checked? Or should they just be trying to get into the hands of an endocrinologist who knows hormones best instead of working with a GP?
Hormone levels, like I said, the only time levels are useful is if we're addressing a problem. So if that athlete is struggling with something with, her periods have changed or she's having the symptoms that I mentioned, then the doctor's going to want to figure that out and check the hormones like thyroid, reproductive hormones, etc. But if you've got somebody that's feeling well and is not having any symptoms, then there's really nothing to check. Because again, especially with reproductive hormones, you can check them at 9 o'clock in the morning and there'll be one thing, and you can check them at 3 in the afternoon and there'll be something else. So it's not helpful because they're changing all the time. So in the healthy state where people are not experiencing any symptoms or issues, there's no need to be checking anything. You're doing everything right. Keep up the good work. Go by your performance metrics, by, whatever training you're doing, go by those metrics. Whatever you're supposed to look like in the mirror at this phase of your prep, that's what your endpoints are. But unless you're having problems, hormone levels are not always helpful. The exception to that is if you have a physique athlete or another athlete, but this isn't typically legal in other sports, that are taking anabolic steroids or other performing enhancing drugs to try to meet that aesthetic. And I know in different areas of bodybuilding, I think some performance enhancers are allowed. This is beyond my expertise. This is not the kind of endocrinology I practice. There are other people who are more well-versed in this. But when you're going through that kind of treatment to achieve a certain aesthetic, you probably want to check levels to make sure that you're in a safe range. And whoever's managing that medication protocol would be able to tell you what the safe ranges are. But other than that, when we're not talking about performance enhancing hormones, there's really no need to check anything if you're feeling well and if you're performing well.
So to drill down on that a little bit more, we have a lot of people who get out of a prep. They may not have had their cycle for months, and they go and get their blood work done. And of course, everything's tanked.
Yeah.
Is that a worthwhile practice, or is it better to give themselves time to, replenish, feel better, give your body a chance to restore itself before getting that blood work done and inevitably seeing that it's all terrible?
Yeah, absolutely. I mean, after you run a marathon, you don't want to walk off the finish line and have your blood drawn because it's going to be a total shit show. So you don't want to do that. Wait for your body to equilibrate. You've just been through a competition or an event. Fuel yourself, let your body rest, recover, give it 6 to 8 weeks. If after 6 to 8 weeks things aren't quite right, then see somebody, and then you can drill down on exactly what isn't quite right and get to the bottom of it.
So you talk a lot about symptoms. We did have a specific question from one of our members. If they are on the older side, so they are 46, but they're not experiencing any symptoms, then do you think they should start seeing an endocrinologist just because of their age, or are we really just talking about symptoms and how people are feeling?
It's really about symptoms and how people are feeling. If you're feeling well at 46, if you're sleeping well, if you're performing well, hell, if it isn't broken, don't fix it. Don't go to a doctor who's going to do something to screw that up. So I would, if you're feeling well, I would say, yeah, just continue going with that. You don't need to see somebody. But if you start to have some issues that you're struggling with, by all means, get them addressed.
Mm-hmm. And then so once you do have symptoms and you are trying to work on getting that addressed, what are some potential risks that people need to consider with hormone replacement therapy?
So we call hormone therapy. We don't really call it replacement therapy because in midlife, in menopause, we're not replacing anything, because to replace something implies that it's supposed to be there. So as we go into that phase of life, we are not supposed to be having our periods anymore. Therefore, our estrogen levels are not supposed to be high. Our progesterone levels are not supposed to be high because we're not ovulating. And our testosterone levels are also in a different normal range than they were when we were in our 20s. So we're not replacing anything because it's not supposed to be there. But what we are doing with the hormones is treating symptoms. And there are some great publications by the Menopause Society and the British College of OBGYNs and the British Menopause Society as well, with guidelines about when hormone therapy is effective, when it isn't, what symptoms it is thought to help with, and what symptoms it's not thought to help with, along with what are the risks and, risk benefits. So the thing when you're thinking about hormone therapy is you want to make sure that the benefits outweigh the potential risks. So if I have a 50-year-old woman who comes to me, she's menopausal, she hasn't had a period in more than a year, and she says, I'm having these terrible hot flashes, they wake me up at night, I can't train during the day, I need some help. She's otherwise healthy, doesn't have any history of cancer, blood clots, or anything like that, no significant family history. She is a perfect candidate for hormone therapy because the benefit is that the hormones are probably going to be very effective for treating her hot flashes. So big benefit to treat the hot flashes. Risks minimal because she's very early in menopause. She doesn't have any personal health problems, blood clots, cancer, whatever, no family history. So that's kind of a slam dunk. Benefits far outweigh the risk. If on the flip side, you have a woman that comes and she is menopausal and say she's morbidly obese, has hypertension, she smokes cigarettes, has a history of ductal carcinoma in situ, which is breast cancer that's, in situ, it isn't invasive. And she's having hot flashes. Well, she could benefit from the hot flashes with the estrogen, but the risks are way too high for blood clots and potentially cancer recurrence. So for someone like her, I would say, you know what, let's try some non-hormonal methods first that are safer for you before we go jumping to something like hormones. So it's really all about knowing, and this requires you to talk to the patient, what their benefits are and what their risks are. And that's just a careful history. Any blood testing is needed to try to work out that equation and give them options so that they can make the decision for themselves.
Do you mind elaborating on the non-hormonal interventions that you just alluded to?
Yeah. So, cognitive behavioral therapy, CBT, is something that the Menopause Society just published on, and it has been shown through some different studies to be very effective for hot flashes. it's not the most practical option because there aren't a lot of people out there who have this expertise. You kind of have to look for them. So, I have a client in Idaho who I mentioned this to, and she laughed at me. She's like, I'm lucky there's a family practice doctor within 2 hours of me, never mind one of these CBT specialists. So it's not always the most practical option. Many antidepressants tend to have great hot flash relief. Like Paxil. Paxil is one that's actually FDA approved. It's the only SSRI, that's the class of antidepressant. It's the only one that's FDA approved for hot flashes. But other SSRIs, other types of drugs in that same class, like Zoloft, Prozac, can also be helpful. There's been some studies to show that they can be helpful for hot flashes too. So if I have somebody who's got significant mood symptoms, say she had a history of anxiety and depression in the past, and now it's reared its head with menopause, and she's having hot flashes, she might benefit from that antidepressant because she's got that clinical history and she has hot flashes. So that's a non-hormonal method. There's another one. It's another FDA approved one. It's called Vizoa. It is an NK beta antagonist. It's something it escapes me at the moment. It just was FDA approved a couple of years ago, but that's non-hormonal and it acts on receptors on certain brain cells to help relieve hot flashes. And then, of course, there's your lifestyle type stuff. You want to make sure your sleep hygiene is good, sleeping in a cool room. There's lots of cooling mechanisms, fans, etc. And, maybe not training so close to bed, not having caffeine or stimulants so close to bed. Those can be triggering for hot flashes. But one of my favorite non-hormonal ways to at least start to address it is by journaling and starting to make associations. Keep a hot flash journal. So like, say, for instance, you have a hot flash at 7 p.m. You mark it down and then you think to yourself, okay, when did I eat? What did I eat? What did I do today? Did I sleep well last night? And if you kind of pick some things and track it over time, you might find out, oh, alcohol's a trigger for that. I can't have red wine is something I have to be careful of. So journaling can be very effective at identifying triggers so that you can then avoid them. So that's kind of like the first step. And then beyond that, we've got pharmacology that's non-hormonal and also, behavioral type things. I'm sorry, there's a boat going by my condo. I apologize.
But you said something really beautiful on a different podcast about first, like this phase of life and how Mother Nature is not, you're not intended to still have a cycle. You're not intended to still, operate in the same way. And I thought that was just really beautiful for, our audience to hear. And then on top of that, you layered onto that with go lift some heavy weights. I feel like that's the intervention that, a lot of women, especially, depending on the decade that they were born, like going and picking up heavy things is not intuitive. There was cardio bunnies and, avoid carbs and just all this misinformation. So do you mind kind of circling back to that general lifestyle intervention that women, especially from the ages of like 45 to 55 can really benefit from hearing?
Yeah, no, that's a really great question. Is my audio still good for you?
Sound great. Yes.
Okay, great. So I want to just back up a little on the first part of your question, because some people get triggered when people like me say that menopause is a natural process. Just because it's natural doesn't mean that you have to die on the vine and succumb to it. That's not what natural means. What natural means is that these things are happening to your body, and if every woman lives long enough for that to happen, it is going to happen to her. It's like puberty. Puberty is a natural process. It's not pleasant, but it's still something that every woman will go through, aside from rare disorders, if she lives long enough. Pregnancy, voluntary, but in most cases, but menopause, it is the same thing. This is a natural process that every woman will go through if she lives long enough. So the key is to understand what's happening, because if you can acknowledge and understand what's happening, you can fight the good fight. You don't know what the terrain looks like unless you start accepting that, okay, the muscles are going to start to lose mass, power, and strength if left untended to. Bone density is going to start to decline. These things are going to happen, but that doesn't mean I have to roll over and die. What it means is that we're going to start lifting weights, because when the hormones aren't there to provide stimulation to the muscles, and when the estrogen receptors are changing, the way around that is you mechanically stimulate the muscles. When they're not being hormonally stimulated, you can mechanically stimulate them. And I can tell you, as a 54-year-old woman, I can bench press right now what I bench pressed in high school. Now I have to work damn hard at it, much harder than I had to in high school, because in high school I could like go out partying at 4 a.m., come to the gym at 7, and then, you know, crank out 120 pounds. I can't do it that way anymore. I have to actually really focus on it, but I can still do it. So the moral of the story is that these things are happening. We have to acknowledge that they're happening and that this is real, and train around it. So lifting weights 2 to 3 times a week, really super important. That's important not just for muscles, but for bones as well. Plyometrics, that's like jump roping, anything that involves jumping. It could be pickleball, it could be tennis, it could be running, it could be just walking. These are weight-bearing plyometric exercises that will stimulate your bones. So you have to kind of think a little bit more about that. The other thing that happens during this phase of life as a result of these hormonal changes is that recovery takes longer. And this is where what I used to do before doesn't work anymore. Well, you know, you might need a rest day now, where maybe you could have gotten away with 3 weeks without a rest day back in the day. Can't do it so much anymore. You can still perform maybe at that level, depending on, you know, where you were. If you're a lifestyle athlete, you know, that's tenable. Professional athletes, where they're in their peak performance, you know, it's hard to maintain that through the age groups, but for you know, for lifestyle athletes, you can probably hold on to your performance for a really long time. By just paying attention to, okay, recovery is not as efficient, so I'm going to pay more attention to that. I'm going to warm up, cool down, take my rest day. I do have to lift weights more often than I used to, and I can't have an ice cream cone every single night, because I have a little bit of insulin resistance now, and I'm a little more sensitive to refined sugars. So, you know, that's why I kind of wanted to preface, because like I said, people get triggered when I say this is a natural process. But if you don't accept it as a natural process and understand it, you're never going to beat it. Then you are going to die on the vine, and it's a self-fulfilling prophecy. So if we understand what's happening during this stage of life, we can take steps to mitigate all those things that are happening, and lead our best, healthy, highest performing lives.
I'm
And
glad
it
that
really
you're
all works out.
It does. It works out.
I don't actually want to party until 4 a.m. and then go lift at 7 a.m. anymore, so it's fine.
No, I was done with that a long time ago.
I'm glad that you're emphasizing so many alternative ways to combat these symptoms, like lifting heavier, monitoring what's actually triggering your symptoms. But for those that are looking to have therapy for their hormones, and since you also mentioned that hormones are different depending on what time of day you're taking them, then how can you really figure out the balance of hormones to be taking?
It doesn't quite work that way. There isn't a balance of hormones to be taking. We take hormones to treat symptoms, because again, this isn't an imbalance. This is our normal physiology. The body's going to do what it's going to do. Mother Nature always wins. So there's no way to balance this. It's balanced. Aside from thyroid disorders, metabolic disorders, and other disorders, those need to be treated. But the normal process of aging and menopause is not an imbalance. So we use hormones to treat symptoms. We don't replace hormones to achieve some sort of balance, because that just doesn't exist.
That's really good to hear, because I think a lot of people in our community, we do go chasing optimal, right? Like we think more is better. And, you know, as women, like if we can have more testosterone, then we're going to be lifting and recovering better and all these great things. But like you said, everyone has their own normal.
That's
So you
right.
can't just load them up and expect for it to turn out okay.
Yeah, I mean, testosterone is a good example. You know, I do prescribe testosterone for some women who are having libido issues or hypoactive sexual desire disorders, what it's technically called. And you could give one woman one dose and get her level to be X. And you could have another woman experiencing the same thing, give her the same dose and have her hormones be X. And she has all these side effects. She's growing hair in places she's never grown it before. She's got insulin resistance and her sugars are out of whack. So, you know, it's really hard to paint everybody with a broad brush stroke. You have to really take each case as individual because different people are going to have different ways that their body metabolizes those hormones, and not one dose or one level is right for everybody.
So we did have one specific question that did touch on libido. Sounds like it might just be better to work with an endocrinologist specifically, but they did ask, why is their libido so low? It's non-existent, but their full blood panel says everything is fine, and it's just driving her husband insane.
Yeah, because there's a lot more going on in the body than what the blood tests tell you. So think about a blood test. Where do we take it from? We take it from a vein in the arm, right? Well, hormones are exerting their effects within the tissues and the cells themselves. So each different organ of the body, the brain, the muscle, the bone, even the tendons and ligaments in the hair follicles, have their own biochemical pathways that are metabolizing steroid hormones in different ways. Your hair follicles have different enzymes that give one testosterone or androgen metabolite dominance where somewhere else doesn't have that same enzyme. So I liken the blood test to being in the middle of the street on a cul-de-sac, and by being in the street, you don't know what's happening in each of the houses. Just being in the street does not give you insight into what is happening in each of those houses. And this is why so many women come to me so frustrated that they feel like they're ready to strangle their husband, jump off a building, but their levels are normal, you know, and the doctor thinks they're crazy. Well, because there's so much going on in the body with hormones that you just can't measure, which is why you have to talk to the patient for like an hour to understand what she's experiencing, because the hormone levels are really going to help us rule out disease. That's all it's going to do. Because there's so much variation in female normal hormone biology, you're just not going to detect a lot of this stuff by checking, randomly checking a panel of hormones.
We had so many specific questions around specific hormones. Go ahead, Diana.
Well, in addition to tracking the triggers like we talked about before, what kind of information would you want to hear from someone when you're talking to them?
How many hot flashes are you having during a given time frame? How many per day? What time of the day are they occurring? Are they occurring exclusively at night, mostly at night? That sometimes tells us something about triggers. If they're happening during the day, well, maybe it's something during the day that's triggered that they're doing that's triggering it. So frequency, timing of hot flashes, really important. Some common triggers that I tell people to pay attention to would be stimulants like caffeine or some of the stuff like a Red Bull or stuff in the pre-workouts. Alcohol is a big one. We become so intolerant to alcohol as time goes on. Many people do anyway. That's a very big common trigger. So caffeine, stimulants, alcohol. Timing of eating, close to your hot flashes. I had one woman who would have a hot flash about 2 hours after she ate. And then when we dug a little further, she loves hot, spicy food and she's pouring the hot sauce on. I'm like, the hot sauce was her trigger after we figured that out. So, yeah. Timing of eating, are you eating spicy foods? Are you eating too close to bed? And if hot flashes are coming at night, you always want to know, okay, basic sleep hygiene is, what temperature is the room? Does my husband snore? Do I have a dog that's sleeping with me? Things like that would be worth tracking.
Do you mind speaking about PCOS a bit more? I think that
Sure.
One, is it underdiagnosed? What can people look for? Give us kind of a high level overview of that.
Yeah, polycystic ovarian syndrome. I have managed a ton of this as a fertility specialist because it is a common cause of infertility, because it is the leading cause of ovulatory dysfunction and irregular periods. In my blog, Performance Edge, I have two blogs, Athletic Aging and Performance Edge. I published a blog very specifically on PCOS. So if you went on to performanceedge.blog, and just search PCOS, you'll find it. And this goes over a whole ton about PCOS and what it is and, who gets it. But basically what it is, this is a hormonal imbalance. PCOS is an imbalance where one is producing more male hormones than they should be. So women produce male hormones. We produce testosterone and lots of different metabolites thereof and derivatives thereof. We also produce DHEA and DHEAS from the adrenal glands. About half of our male hormones comes from the ovary, half of it comes from the adrenal glands. And when these organs are producing too much of it, it can interfere with the signaling of the menstrual cycle hormones. The pituitary gland secretes hormones that tell the ovary to develop and ovulate an egg, and the ovary talks back to the pituitary gland saying, all right, we have an egg, it's ovulated, now, now what? So there's this hormonal conversation that goes on that gives you a regular menstrual cycle, but when there's too much male hormone floating around, it causes interference. And so those signals don't make it to each other, and so people miss periods. Sometimes they get no periods at all. This is also associated with hair growth. People can experience hair growth on their face, middle of their chest. It's usually coarse, dark hair. And this syndrome also makes them more susceptible to what's called metabolic syndrome, which is diabetes, high blood pressure, high cholesterol. It is oftentimes associated with obesity, more common than not, it is. But there is also a lean PCOS type where people are of normal to lean body habitus, and they have this same problem. So it can wreak havoc with the menstrual cycles. It can wreak havoc with metabolic health. If one is obese, low glycemic carbohydrates are good. Low carb diets are actually pretty good for people with PCOS under a supervised program, because you can't sustain it for too long, or else you'll wind up in low energy availability. But this is a metabolic disorder that should be treated to optimize health, ovulation, etc. And it is underdiagnosed. It is severely underdiagnosed, for sure.
Thank you for addressing that. It seems like it's coming up more in conversation, and it's good for people to know how it may affect them. You mentioned all of the indicators, but even in their training as well. And I want to hone in on something you said about the body types and the propensity towards obesity. Do you see it more commonly, and this is a bit more anecdotal possibly, but do you see it more commonly in certain body types, like women who maybe are holding more weight in their torso, their abdomen area, have different types of weight distribution?
As far as weight distribution, we know that truncal obesity is common in people with PCOS. The thing we don't know, it's a chicken egg problem. Did the PCOS cause the obesity, or did the obesity cause the PCOS? We don't know the answer to that. We just know that oftentimes the two run together. But when people are able to achieve weight loss through dietary management and exercise, a lot of the male hormone elevations can actually resolve themselves. They can get their periods back and lower their risk of metabolic syndrome.
That's very optimistic and good to hear, especially if people are getting into a specialist. If somebody suspects that they may have PCOS, where would they start in a treatment plan?
Well, we have to get the correct diagnosis. This is one thing that my gynecology colleagues don't always get right. Sometimes I would say it's underdiagnosis, but it's also overdiagnosed too. When people come to me and say, oh, I was diagnosed with PCOS, and they don't meet any of the diagnostic criteria. The most popular diagnostic criteria is called the Rotterdam criteria. That is 2 out of 3 of the following: irregular periods, lab value. This is where we would be checking labs for testosterone and DHEA. Those are adrenal and ovarian hormones, androgens. Lab evidence of elevated androgens, or the coarse hair growth that I was talking about before. And then the third thing is ultrasound evidence of a certain pattern of follicles on the ovaries when you look at it on ultrasound. If someone has 2 out of 3 of those, they have the diagnosis. So it's a very common, it's the most well-accepted diagnostic criteria, but your OBGYN would be your first stop. And then hopefully they're familiar with PCOS. They might send you to the reproductive endocrinologist, especially if you're trying to get pregnant. If you're trying to get pregnant, they may send you to the reproductive endocrinologist sooner rather than later. But typically someone like me sees a lot more PCOS than the general GYN. But the general GYN should still be familiar with it because it is common enough in the population.
Yeah, and having that criteria for diagnosis seems very important because, like you said, it's an awful thing to get diagnosed with if it's wrong. So that doesn't help you either.
That's right.
Diana, as we're wrapping up, are there any, I know we didn't get through all the questions. Do you have any other must-ask questions?
Well, as you're talking about seeing your doctor, I feel like a lot of women talk about not getting their needs met. They want certain things checked, but their doctors are pushing back. So what do you recommend for women for advocating for themselves?
Is to make sure that the information, and this is easier said than done because it's a whole sea of information and misinformation out there. There's a huge push in the industry. Get labs, get labs, get labs, get labs, because the people who put the labs out make a lot of money when you get labs, get labs, get labs. And so your doctor may push back. And I will tell you, I do sometimes push back on patients saying that that lab's not going to help you. You're only going to be spending money on something that is not going to help you. Now, they may bring me their Dutch test, which is fine. I think Dutch does a really good job at what they do. And I interpret tons of these things. But again, what I notice is that there's only a few select things on the Dutch test that are usually relevant for what the patient is experiencing. So you want to be careful of where you get your information. The first thing you want to know is the person giving you information financially benefiting if you use their product? Because that might signal, well, you know, they're giving you a perspective through their lens because they're a business and, you know, they're trying to make a living. So you want to be careful of the sources to make sure there are no financial conflicts of interest. There is a great company that I actually am an advisory stakeholder of. I joined this group. It's called Feisty Media. It's a media company. They do a ton of work in the performance space. Feisty Menopause is led by my now friend Celine Yeager. She is a competitive cyclist. She's a professional cyclist, actually, former Ironman All-American pro athlete. And she started this Facebook group that started with 1,400 people and now has like 20, 30,000 followers. Really great resources there in that space. And also Feisty Media's performance brand caters to the younger competitive individuals. A lot of these women are in the endurance space and they're competitive elite. Some are pro athletes, but others from the CrossFit world, the Peloton world, the running world, the weightlifting world have come over to this resource as well. So I can tell you that Feisty Media has lots of great reputable resources and courses to help people get good information and not information that might be tainted by financial conflict of interest.
So become more educated so you can advocate for yourself.
Yes, exactly. Exactly. You know, I have plenty of patients that come to me. It's like, look, my doctor isn't comfortable giving me hormone therapy. Is there something I can take to them? And I say, yes, here is the hormone position statement from the Menopause Society. And I'm going to circle this paragraph to let them know that it is okay to give you vaginal estrogen while you're taking the estrogen patch. So yeah, you have to connect with experts in the field who really know what they're talking about, you know, who are unbiased. And those resources are out there and you can bring them to your doc and hopefully your doc will be receptive.
That's great. And we'll make sure that we link Live Feisty in the notes here. As we wrap up, is there anything that we did not ask that we should have asked or any messages that you want to make sure are shared with the community?
I think the one message I always want people to take home is that your body is not the enemy. Your body goes through so many changes through its lifespan if you are female. And it's really, as unpleasant as it can be, it's really a gift. We've been tasked with, carrying and creating life in our bodies. And that requires a lot of physical prowess to do that. We have an incredible capacity for physical adaptation that Mother Nature has just inherently programmed into us. So if we can work with that physiology instead of against it, when we're menopausal, trying to still be 30, that is going to be a losing battle. Rather, understand what Mother Nature has had programmed into us, with probably very good reason, and say, okay, this is what the landscape looks like right now, and this is how I'm going to best traverse it. But your body's been by your side your whole life. It needs you more than ever during these times. So learn what it needs, and it will be there for you until the end of days.
That's amazing. And if people wanted to learn more with you, how can they get in contact with you?
My website's best place to get in contact with me. It's www.drcarlad.com. My practice is open for consultations. And so you can book an appointment for a consultation right on my website. But if you want to just reach out to me, you can just do the contact us. You can just write me a message. I'll get it directly. You could also follow me on Instagram. It's at dr_Carla_D. And you can also message me through Instagram as well.
Wonderful. Your Instagram's fantastic. And I did want to note too, the blog that you mentioned, it looks like these are actually newsletters as well. So people can sign up for Athletic Aging and Performance Edge.
Yes. Yep.
Excellent. Well, this was wonderful. Thank you so much for what you're doing for the community, for women as a whole, to make sure that we are keeping our edge at every phase of life. We really appreciated you coming on today.
Oh, it's my pleasure. Thank you for having me.
Amazing. Well, we hope to get to speak with you soon. And if anyone else has any questions, definitely reach out to Dr. Carla.